Thank you, Dr. Newsom. That's a tough act to follow. My sons would love your Avenger theme. Again, I'm thrilled that we're here today. I wanted to tell you when I thought about, well, what would I really want to talk about? I'm an oculoplastic surgeon, and this year's been a tough year for all of us with COVID. But there was one shining light this year that really got me excited about my practice and kind of was a game changer. So I'm excited to talk to you guys about that today. We're going to talk about the advances in thyroid eye disease management. I have been a consultant and an advisor for Horizon Therapeutics. I'm not on their speakers bureau. I don't have any other financial interest with them. So I actually went into the field of ophthalmology because as a med student, I met one patient, actually it was on my Odo rotation, who underwent an orbital decompression. And I saw the lookbook of the transformation that these in the US, it's typically middle-aged women, but that these patients went through. And I thought, gosh, I really want to be a part of that. So I went into ophthalmology for thyroid eye disease. And actually I did an oculoplastics fellowship thinking I was going to be a person that specialized in thyroid eye disease. But you know what, after fellowship, I practiced for a few years. I built up a big practice of thyroid eye disease patients, founded a regional support group. And then I kind of lost my passion for it. And I really felt, because I felt like I was helpless. I held their hands through the disease process, but I didn't have good tools in my toolkit. And it was really frustrating. But this year, everything has really changed for me. I'm going to start out by telling you a story of a woman, and you're going to feel the emotion of why it's so hard to take care of these patients if you don't take care of thyroid eye disease patients. But most of us encounter them somewhere in our practice. This woman was diagnosed with Graves' disease in 1992. She had lid retraction and proptosis at the time. And then in 2011, she came to us with binocular diplopia and eye pain. Over that time frame, she'd had anxiety, depression. They caught a vitamin D deficiency, which we now know is related. We didn't know back then. She wasn't a smoker. Her thyroid levels had been stable. Her vision was good, but she had motility restriction. And this is how she looked. 2012 was not her year. She came back 6 months after that presentation in 2011, more light sensitivity. She didn't have optic neuropathy, but she was started on the Kahali protocol with IV solumedrol or methylprednisolone, and that's 6 weeks of 500 milligrams followed by 6 weeks of 250 milligrams once a week. Her liver enzymes went up. But she did continue on the steroids. And then after completing the steroids, she had rebound inflammation and developed compressive optic neuropathy. She underwent orbital decompression on each side sequentially, and then her pain improved, but she developed binocular diplopia. She had strabismus evaluation, didn't tolerate Fresnel prisms, and ended up having strabismus surgery. Then from 2013 to 2019, she had multiple eyelid surgery. She developed cataracts from all her steroids, but she was relatively stable. And this is that period in taking care of these patients where you think, gosh, she's not totally happy, but we're getting her there with the idea that we're putting her back to her pre-disease state really isn't true, right? We're trying to improve at her, but she's really not back to her pre-disease state. But she was getting along okay. And then in 2020, she came to me and said, oh, I have new onset double vision. I have pain. All those emotions, anxiety, depression is coming back. So this is the list of what we had in our toolkit in 2019 and in early January of 2020. And you can see all the different things we can treat her with. The reason there's so many treatments is because none of them are good, right? None of them really cover all the bases and take care of everything. If you look at the UGOGO and the European groups, what they've recommended is you can see they're really heavy with steroids. You can see each of these pathways kind of lead to steroids, but there's issues with steroids. Oral steroids are really only 60% beneficial short-term to reducing those inflammatory signs, and there's no proof that it helps strabismus. IV corticosteroids are about 70% effective in reducing inflammation, but there's lots of other issues with them. And steroids are not useful for strabismus or eyelid retraction typically, and they really just have a mild effect for proptosis. Some people will advocate for radiotherapy, and you're going to have a great panel later on today on thyroid eye disease. So you'll hear some of the proponents of each of these. And radiotherapy decreases inflammation, but it doesn't really have any benefit on proptosis or lid retraction. It may help compressive optic neuropathy. And again, we can't use it for younger patients. It can cause cataracts and radiation retinopathy. Now, in the US in January of 2020, Tepa Tumor Map was approved, and this is a human monoclonal antibody against the insulin growth factor 1 receptor. It's being used for active, moderate, and severe thyroid eye disease, and really it's targeting that insulin growth factor 1 receptor, which sits on the orbital fibroblast there. The studies were done in patients that were newly diagnosed with thyroid eye disease within the last 9 months or so. So I just kind of tried, I had the privilege of being the primary investigator on the phase 2 trial for Tepa Tumor Map here at the University of Iowa. And then there's also a phase 3 trial. So as you can see, there are 8 infusions. Every 3 weeks, the patient gets an infusion. Really about 80 patients total got Tepa Tumor Map and finished the course of it. And what you can see is looking at the 24 weeks that there was a significant difference in the improvement of proptosis of greater than 2 millimeters. Over 70% of patients had an improvement compared to 20% and 9.5% of the placebo patients. And then the proptosis reduction was about 3 millimeters in the Tepa Tumor Map patients compared to the placebo patients. Just because of time, there was a slight change in the proptosis of the placebo group as well. Now, if you look at some other measures in the phase 3 trial, double vision did improve, but it didn't resolve completely in a lot of the patients, but they did have an improvement of 1 grade, whether it was in primary, end gaze, or intermittent double vision. The quality of life score improved, and the CAS, that clinical activity score, also decreased at the 24-week period. So those were really promising results, and we were really excited to get it approved in the US. There are some adverse events. In fact, inflammatory bowel disease is a significant one. And so those patients were actually excluded from the phase 3 trial. Patients have had diarrhea, muscle spasms, mild nausea, and some hearing impairment, which all resolved subjectively by the end of the study. This is from that New England Journal paper. You can see the placebo patient really didn't have much change. If not, it had worsening of the lid retraction, injection, and proptosis. And then the Tepa Tumor Map patient had improvement, and you can see the scans there below. But this is from the New England Journal paper, so this is probably the best patient in the study. So I thought today I'd just show you some of my patients. I've had the pleasure of being able to treat patients now with Tepa Tumor Map. We started about midway through the year. And so I've had a number of patients that have completed all 24 weeks. And so I wanted to share a couple of them and their stories with you, because I think this is, at this point in this drug, this is kind of where we are. If you're looking for data that doesn't come from the companies, right? It doesn't come from the actual pharmaceutical company, because you'll hear more later today about some other trials from them. So this was a 42-year-old patient who had thyroid eye disease. He'd been on the for about 2 years. He'd been on the Kahali protocol, so he'd had IV Solu-Medrol. He'd had 12 weeks of that. He had oral steroids after that because he had some rebound inflammation, and he even had a thyroidectomy. And then with the Tepa Tumor Map, you can see after the 8 infusions, he had approximately 3 millimeters of reduction in proptosis in both eyes. He still has lower lid retraction. He still has temporal flare. He still has a little upper lid retraction, but he has a noticeable decrease in his CAS score, his comfort. In fact, he had significant muscle spasms that really affected his quality of life, but he decided not to stop the drug because he was so excited about how his eyes were feeling and looking. So that's one example. This is another patient who is a 58-year-old who had thyroid eye disease, and he underwent an orbital decompression for compressive optic neuropathy. I met him and operated on him the next week for a compressive optic neuropathy, and then he had some oral prednisone just coming off of the decompression. But then after the decompression, he still had diplopia and discomfort. And so we started him on Tepa Tumor Map. Again, we are not really sure who the right patients are for this drug at this point in time. So we started this gentleman on it, and you can see he's had a 2.5 to 3 millimeter reduction in proptosis. The interesting thing about him is that his wife does not like his appearance. She feels like his eyes look too sunken in and ophthalmic. And so that was one cautionary tale. Now that if we're going to have the potential to use Tepa Tumor Map, we've got to be careful potentially about doing orbital decompressions and the sequence of those. And this patient tolerated Tepa Tumor Map very well. He had no symptoms or side effects that he could tell whatsoever. This is a woman who, talking about a long history, she's a 30-year-old. She had 13 years of thyroid eye disease and had orbital decompression, and then was doing well, but had a reactivation. She underwent the Kahali protocol again, so 12 weeks of IV Solu-Medrol. And then I actually put her on tocilizumab, and she didn't budge. You can see this is what she looked like after. This is after her decompression and all those treatments. She's halfway through her cycle now with Tepa Tumor Map, and you can see she's had 1 and 2 millimeter reduction in the proptosis. But interestingly, her lid retraction has improved significantly, and that's not something we're always seeing. So why did her lid retraction improve, but other patients, their lid retraction is not improving as much? It's very interesting. She also has been tolerating it very well. And then I thought we'd go back to this patient. So this is the patient that had had 28 years of thyroid eye disease. You can see she's having this new onset double vision, pain, pressure. motility issues as well. And I said, let's just see how much of this is inflammatory. So I put her on 3 days of 60 of prednisone, and she said, I feel like a new woman. I feel fantastic. All that anxiety and depression was going away, and she was excited again. But I said, think about, do you want to go back on steroids? You've been on both IV and oral in the past. And didn't tolerate those wonderfully. Or do you want to maybe consider this new drug? We don't know if it will work in you after having thyroid eye disease for 28 years. Well, she got on Facebook. There's a Facebook group for thyroid eye disease patients. She got on Facebook, and all her friends on Facebook told her to do it. So we put her on Tepa Tumor Map, and she is thrilled. Her proptosis improved 3 millimeters on the right and 4 millimeters on the left. Her echo at the end of the 8 doses showed that 1 millimeter reduction in each of the extraocular muscles for 6 of the 8 of them. And her motility has improved. She still has lid retraction. Mind you, she's had lots of lid surgery. So her lids still look like she's had multiple surgeries, but she's doing much better. Interestingly, she thanked me for getting rid of her tinnitus. And we've been doing audiology testing on some of these patients, because we don't have objective data. And we did find that she had some hearing reduction, which which improved her tinnitus as well. And we're waiting to see if, as 3 months after her protocol, we are going to start her back with an audiology test and see if that hearing improved as subjectively the patients did in the study. So the Tepa Tumor Map is now approved in the US for thyroid eye disease. It's our only approved drug. There's other drugs in the pipeline. In fact, the University of Iowa is participating in a study looking at increased catabolism by IgG in a subcutaneous medication rather than this IV infusions we're getting with the Tepa Tumor Map. But there's a lot we don't know, right? We don't know who's going to respond, how long of a window you have. Maybe Rundle's curve is shot. I mean, we don't really, Rundle's curve needs to be revisited. We need some investigator-initiated trials. We need to look at these patients critically and the side effects critically. And we need some head-to-head trials. We need also international access, because we know that that thyroid eye disease is a different beast in different countries and around the world. So we look forward to hopefully branching out. The Horizon Therapeutics has said that they're looking now at expanding beyond the US with the drug. So hopefully that will happen in the near future. Thank you again for the opportunity to be here today. This is what it looks like in Iowa right now. This is my email, and this is both my Twitter and Instagram handle. So I look forward to, happy to have any of you reach out. Thank you again for the opportunity. I'm going to turn it back to Lisa, who will introduce Dr. Pappas.